Today we're going to be taking a look at pre-renal acute kidney injury as part of the renal series. The best place to start this topic is by first understanding the basic anatomy behind the urinary tract system. If you remember, we have two kidneys which help to filter the blood and create urine. This urine is then transferred via long tubes known as the ureters, eventually reaching the bladder for storage. Importantly, blood enters the kidneys via the renal artery, and then the filtered products return to the blood via the renal vein. As we mentioned, the primary function of the kidneys is to filter waste products and maintain a good balance of water and electrolytes in the blood. And the way this is achieved is through specialized functional units known as nephrons. If we take a closer look at the nephron structure, we can see that it's composed of several different parts, and we're mainly going to be focusing on the first part, the renal corpuscle, for pre-renal AKIs. The renal corpuscle is formed of a Bowman's capsule, which is this outer covering, as well as the glomerulus, which is basically a loop of capillaries designed to increase the pressure. Blood enters the glomerulus via an afferent arteriole, and then exits via an efferent arteriole. And the whole purpose of the system is to use the thin walls of the glomerulus and combine this with the high pressures to force small molecules out of the blood and into the nephron tubules. Just to make things easier, we're going to represent the renal corpuscle like this. Again, we have the afferent arteriole bringing blood in, the glomerulus in the middle, and the efferent arteriole bringing blood out. The remainder of the tubules and the blood vessels surrounding the nephrons we're going to simplify like this. So in essence, we have a simplified diagram of an entire nephron here. When it comes to the topic of acute kidney injury, this can be defined as a sudden decline in renal function, which leads to a buildup of serum creatinine or a decrease in urine output. The reason why we tend to use serum creatinine as a marker is because creatinine is a product of muscle breakdown, and importantly, it's freely filtered into the kidneys, and it's not reabsorbed back into the blood. In this way, the amount of creatinine entering the kidneys should be roughly equal to the amount leaving it via the urine, which makes it a good marker for kidney function. We actually have a guideline known as the KDIGO classification, which helps to define AKI according to specific criteria, and if any of the criteria are present, it confirms the presence of an acute kidney injury. The first criteria checks if the serum creatinine has risen by more than 26.5 micromoles per liter in the last 48 hours. Alternatively, if the patient has a baseline creatinine, and the current creatinine level is 1.5 times or more greater than this baseline, this would also confirm an AKI, as long as it happened within a 1-week time frame. Finally, we can also look at urine output. So if the urine output is less than 0.5 milligrams per kilogram per hour for more than 6 hours, this would also confirm the diagnosis. It's worth noting that acute kidney injury can be further divided into different stages depending on the severity of the condition, and we can use the serum creatinine baseline or the urine output to determine whether a patient is stage 1, stage 2, or stage 3. Regardless of the severity of an AKI, there must be a problem somewhere in the urinary tract system to have resulted in a rise in serum creatinine, and we can divide the urinary system into its constituent parts to work out where the problem is. For example, there could be a pre-renal AKI, which involves insufficient perfusion of blood. There could be an intrarenal AKI, which involves damage directly to the kidneys themselves, or there could be a post-renal problem, such as obstruction of the urinary tract output. In this video, we're mainly going to be focusing on the pre-renal acute kidney injury, where there are changes to the blood supply of the kidneys, and as a consequence is insufficient filtration. To explain this, we have a diagram of the normal nephron structure here, and what usually happens is that there's a high enough blood pressure for small molecules to be forced out of the blood and into the tubules, and this would lead to a normal GFR. If we compare this to a pre-renal AKI, in this case, for some reason, there's a decrease in the blood flow to the kidneys, and as a consequence, there's not enough blood pressure to actually force the molecules into the tubules themselves, and they remain in the blood. This would lead to a reduced GFR. Over time, because of the lack of filtration, there's a buildup of nitrogen-containing waste products in a process known as azotemia. Possible causes behind a pre-renal AKI can include hypovolemia or renal artery pathology, and we're going to start by looking at hypovolemia first. Now, hypovolemia can actually be divided into two types. There's absolute hypovolemia and relative hypovolemia. Starting with absolute, in this case, there's a reduction in both the plasma volume and the intravascular and extracellular fluids. So both of these go down, usually because the fluid is lost somewhere externally. This can occur due to hemorrhage, vomiting, burns, or diarrhea. In contrast, relative hypovolemia involves a redistribution of fluid from the plasma into the intravascular and extracellular fluid space, and this may occur in conditions such as heart failure, liver failure, or distributive shock, such as sepsis. The reason why this is called a relative hypovolemia is because the overall fluid level still remains the same, but the level in the plasma has redistributed itself into the other spaces instead. If we now take a look at the other example of renal artery pathology, some patients may develop renal artery stenosis, which is basically a narrowing of the renal artery, usually as a result of plaque buildup. Again, this would lead to reduced blood flow and poor perfusion to the kidneys, resulting in poorer filtration as well. The most common cause of renal artery stenosis is this atherosclerotic plaque buildup, but in some instances, it can be caused by more rare conditions such as renal fibromuscular dysplasia, where the renal artery is naturally more stiffer compared to normal individuals. Another example of renal artery pathology is a renal artery embolism, and this is where a blood clot is transferred to the renal artery from a different part of the body. Because the embolus is occluding the renal artery, we again get reduced blood flow to the kidneys and poor perfusion. In all of these cases, a pre-renal acute kidney injury will lead to a reduction in perfusion and a decrease in the blood pressure reaching the kidneys. This low blood pressure is often detected by specialized cells, which then activate the renin-angiotensin-aldosterone system. Aldosterone has multiple effects on the kidneys, including increasing sodium reabsorption and increasing water reabsorption as a consequence of this. As water moves back into the blood, it also drags particles of urea with it as well. But the only substance which is not reabsorbed, as we mentioned at the start, is creatinine. Based on these changes, we can work out the signs and symptoms of a pre-renal acute kidney injury. Starting with the sodium level, we can see that there's quite a low amount of sodium in the urine because of this reabsorption process, so we end up with a urine sodium of less than 20 milliequivalents per litre. We also have less water in the urine because it's not filtered as well, and the amount which is filtered is often reabsorbed in an attempt to maintain the blood volume. Waste products such as urea and other nitrogen-containing compounds build up over time, leading to azotemia. If we take a look at the blood urea nitrogen to creatinine ratio, this is often greater than 20:1 in a pre-renal AKI. And the reason why this occurs is because of this reabsorption of urea compared to the lack of reabsorption of creatinine. In reality, the levels of creatinine in the blood will also be quite high because the substance isn't being filtered properly. However, the levels of urea and other nitrogen compounds will be even higher because they're not being filtered properly, and there's also some unintentional reabsorption because of the aldosterone activation. As the waste products build up, patients often develop symptoms such as nausea, vomiting, and fatigue, and this is often combined with a poor urine output. In terms of the diagnosis for pre-renal acute kidney injury, this can be assisted with blood tests, which look for features such as azotemia and electrolyte changes like hyperkalemia. As we mentioned, we can also look at the blood urea nitrogen to creatinine ratio, and if it's greater than 20:1, it leans more towards a pre-renal cause of the AKI. Urinalysis can also be useful, looking for a urine sodium of less than 20 milliequivalents per litre. Importantly, the urine in a pre-renal AKI is usually negative for blood and protein, and this is because there's not been any damage directly to the kidneys themselves. However, there can be some exceptions to this, especially where a pre-renal AKI persists for too long. Finally, we can take a look at imaging modalities such as ultrasound and renal arteriography, and this can help to identify features such as renal artery stenosis. For the management of pre-renal acute kidney injury, this largely depends on the cause behind the poor perfusion. So for instance, in the case of absolute hypovolemia, we can replace this with IV fluids or blood transfusions. If the hypovolemia is relative, so there's redistribution issues, we have to look at the cause behind the redistribution. So for instance, in distributive shock, where there's a sepsis, we can use the sepsis 6, giving IV antibiotics, IV fluids, and oxygen if required. For patients with relative hypovolemia secondary to heart failure, we might have to consider inotropes instead. In terms of renal artery stenosis caused by plaque buildup, this can often be treated with antihypertensives in the initial stages to prevent further growth of the plaque. However, if this is identified later, renal artery stenting can be another option. Finally, in renal artery emboli, patients may be offered anticoagulation, or in some instances, thrombolysis or thrombectomy. Here we have a summary slide outlining everything I've gone through in the video. I hope you found this helpful, and I'll see you in the next one.